Hello guys, welcome back to this channel. So in the last video that was about the stroke, we discussed about the indications, contraindications of giving tissue plasminogen activator if the patient has come in less than 4.5 hours. So indications we all know when the age is more than 18 years of the time duration. I've already told more than 4.5 hours. There is no intracranial hemorrhage on CT and patient is clinically it's deteriorating and there's a functional neurological deficit. Now, what are the contraindications? In the contraindication, the first and the foremost is that there should be no hemorrhage. There should not be any history of hemorrhage in last 3 months, no history of head trauma, recent surgery, spinal surgeries in the last 3 months. Then patient should not be on heparin from last 7 days. Then the duration of onset of symptoms should be less than 4.5 hours. Otherwise, it becomes a contraindication. The BP should not be more than 185 by 110. There should not be intracranial hemorrhage, as I have already told. Apart from this, if there's a multilobar infection and it is involving more than one-third the area of the brain, again, it becomes a contraindication for the LTCs. For the today, we are going to discuss further what are the surgical interventions we can go and what kind of general management we can do, what is the stroke unit, what are the components of it, and then if you are, what is the general overall management. I already told that management of stroke is not just a giving of LTP. It's a whole bunch of things that we need to do, and that is what we are going to discuss today. So let's start from where we left in the last. So let's start from here. What are the indications of surgery in ischemic stroke? Now, this will depend upon the amount of area it has taken in the stroke, amount of area that has been damaged of the brain parenchyma. So we'll read each and every statement very carefully, because if in each and every scenario the treatment is different, the surgery is different. If the complete MCA territory has been infarcted, in this case, we have to go for a decompressive hemicraniectomy and should be operated as early as possible, mostly within 48 hours. Now, if there's a large cerebellar infarct, then we have to go for a suboccipital craniectomy. In case of cerebellar hemorrhage, we have to go for a suboccipital craniectomy along with the surgical evacuation of the hemorrhage. If there's a symptomatic hydrocephalus, then CSF diversion has to be put. If there's a large cerebral infarct, we have already told we have to go for a suboccipital craniectomy. In cerebral hemorrhage, I have already told you, and in hydrocephalus, already discussed. So in the next slide, we are going to talk about what is the immediate specific management of ischemic stroke. Hemodilution therapy is not recommended. There is no role of neuroprotective drug as such in these guidelines. If there is an intracranial hemorrhage, the treatment has been divided into three parts. One is the role of antithrombotics and antifibrinolytics. It's not antifibrinolytics, then vitamin K antagonist and indications of surgery for intracranial hemorrhage. So when we are talking about indications for surgery for intracranial hemorrhage, what does we want to convey? We want to convey कि हर intracranial hemorrhage की surgery होना जरूरी नहीं होता है. कुछ केसेस में एंटी थ्रोम्बोटिक्स देते हैं, कुछ केसेस में हम विटामिन के एंटागनिस्ट देते हैं, एंड पेशेंट डू रिकवर्स बाय दैट. So giving of anti thrombotics, so what we do is, if ICH is related to heparin, when the patient is on heparin, so our role is to stop the heparin and give the antagonist in the form of protamine sulfate. If the ICH is related to warfarin, then we have to again give the antagonist vitamin K 10 mg IV, fresh frozen plasma 15 to 20 ml per kg, and prothrombin complex concentrate PCC. If it's a symptomatic hemorrhage after thrombolysis that is due to tenecteplase or alteplase, if we have already told if fibrinogen is less than 100 mg per deciliter, then we give a cryoprecipitate 0.15 units per kg and 4 units of PRP. So 4 units of PRP is given in the case if there is a thrombocytopenia. So, right now, when do we give a vitamin K antagonist? If the patient is at a very high risk of thromboembolism and when patient has a mechanical prosthetic valve, vitamin K antagonist therapy is restarted 7 to 10 days after the onset of intracranial hemorrhage. In cases with the lower risk, it is restarted on antiplatelet therapy. So if the patient has a very high risk of bleeding again or thromboembolism, we start with vitamin K antagonist. And if the patient is at a low risk, we give antiplatelets after 7 to 10 days of the onset of hemorrhage. Now, immediate specific management of cerebral venous thrombosis. In case of cerebral venous thrombosis, we give a full dose of anticoagulation. May it be a heparin or the low molecular weight heparin. These are better than the oral anticoagulants, such as warfarin or acromegaly. Now, target INR should be kept 2 to 3. What is a general management in all these processes? It's very important that we do a general management, ICU management of the patient coming to you with stroke, airway, breathing, circulation. So maintain the oxygen level. If a patient comes to you with the oxygen level of less than 90%, give him a oxygen through a nasal prong, through a venturi mask. Body temperature, every 4 hourly, ICU, the temperature should be monitored. And in a bedside patient, in a ward patient, twice daily, temperature should be monitored. If the temperature is more than 99.5 degree Fahrenheit, give a paracetamol. If less than 95 degree Fahrenheit, remove the wet clothing, cover him with the blankets, provide warm drinks, use warm, dry compresses. Do not directly apply the heat. Passive rewarming, blood rewarming, warm IV fluids, airway rewarming can also be done. Blood pressure monitoring, we have discussed in detail in further slides. Blood glucose monitoring, renal function test. So what happens in the patients of stroke, usually, uh, especially in the case of hemorrhage, there's a renal clearance is reduced. So we have to keep a very good check on a renal function test. For cerebral edema and intracranial pressure, there's a whole slide dedicated to this. We'll discuss further. Then we have already told how blood pressure. So what are the indications to start antihypertensives? One is a hypertensive encephalopathy, malignant hypertension, hypertensive cardiac failure, myocardial infarction, aortic dissection, preeclampsia or eclampsia. So when do we start the antihypertensive? When the blood pressure is more than 220 by 120 or mean arterial pressure is more than 120. What is the goal? In the previous guidelines we studied, the goal was to reduce the blood pressure by 25%. But this guideline recommends the reduction of blood pressure by 15% in 24 hours. It should be slow and mostly with the oral medication until or unless contraindicated. Sublingual use of antihypertensives is not recommended. Then blood pressure reduction to 185 by 110 or lower should be considered in the patients who are to be thrombolized. We have already told that the BP more than 185 by 110 is a contraindication for thrombolysis. So if you want to do a thrombolysis, reduce the BP below 185 by 110. So pre-thrombolysis, if the BP is 185 by 110, we give injection labetalol 10 to 20 mg IV over 1 to 2 minutes and repeated every 10 minutes to a maximum dose of 300 mg. And we can also start an infusion at 1 to 8 mg per minute. If in any case labetalol is not available, we give a NTG nitroglycerin 5 microgram per minute or nicardipine at the rate of 5 mg per hour. Uh, Nitroglycerin dose can be increased every 3 to 5 minutes up to the maximum dose of 200 microgram per minute. Nicardipine dose can be increased from 5 mg per hour we have started. We can increase it 2.5 mg every hour, every 2.5 mg per hour every 5 minutes up to the maximum dose of 30 mg per hour. Post thrombolysis, every we have already told every 15 minutes for 2 hours, every 30 minutes for 6 hours, and for next 16 hours. The goal of the BP should be less than 180 by 105 mm of mercury. In case of intracranial hemorrhage, if the systolic blood pressure is more than 200 and mean arterial pressure is more than 150 mm, so it is aggressively treated with parenteral antihypertensives. If the in ICH the BP is more than 180 and mean arterial pressure is more than 130, use of oral antihypertensives are preferred. In this, the goal of the BP is 140 by 150 for at least 7 days. What are the agents we use? So we have oral agents and we have IV agents. Both. So orally, you can give a captopril 25 mg per orally, clonidine 0.1 to 0.2 mg per orally, labetalol 200 to 400 mg per orally, amlodipine 2.5 to 5 mg. Or we can also give infusions. Captopril oral dose can be given. Clonidine, these are of hypertensive emergencies. Captopril, clonidine, labetalol, amlodipine. In parenteral, we can give a short-acting escimalol, 400 microgram per kg bolus injection or in infusion form. Phentolamine 0.5 to 10 mg IV bolus, phenoldopam 0.1 to 0.3 microgram per kg per minute IV infusions. Now, role of blood glucose. Uh, it is very important that oral hypoglycemics should be discontinued as soon as the patient is admitted to the hospital and should be started on a basal bolus or a sliding insulin regimen. The goal is to maintain the blood glucose between 140 to 180. If the blood glucose is more than 150, it should be managed with insulin administration according to the sliding scale. If the uh, if the patient is going into hypoglycemia, we should give 20% glucose. It's very effective. Now, in the case of cerebral edema and raised ICP, first of all, corticosteroids are not recommended. We have to restrict the fluid, elevate the head end of the patient by 30 degrees, correct the hypoxia, correct the hypercarbia, and correct the hyperthermia. After that, we have to give 3% hypertonic saline. It should be infused to keep the sodium levels of 145 milliequivalent per deciliter. Patient should be advised hyperventilation because it acts immediately. It reduces the PCO2 by 5 to 10 mm and lowers the ICP by 25 to 30%. But that's a double-edged sword. Hyperventilation can also cause ischemia and can cause vasoconstriction and can aggravate the ischemia. To reduce the ICP, we give 40 mg furosemide. If required, 20 mg OD furosemide can also be added for the first week. 3% hypertonic saline or acetazolamide may be added who are not responding. Strict urine input-output charting should be done to avoid any kind of dehydration. Patient with altered consciousness, very important. Patient with altered consciousness should be given mannitol, very fast, 0.5 gram per kg over 20 minutes every 6 to 8 hours. This may be continued for 3 to 5 days. So in case when the condition is deteriorating, that is in case of herniation syndrome, patient should be hyperventilated, put on mannitol, furosemide, CSF drainage, and surgery. And in hydrocephalus, we know the treatment is CSF diversion. Early supportive care, very important. Positioning, we have already told, 30-degree head and elevation. Swallowing, if the patient is unable to swallow, put a nasogastric tube. Keep the oral hygiene good. Early mobilization to prevent any kind of a bed sores. Nutritional requirement should be fulfilled if the patient is taking orally well and good. If not, we have to give it through the NGT or enteral or parenteral. Management of seizures, because the patient is lying down for a long period of time, patient can develop deep vein thrombosis. So patient should be put on heparin or a low molecular weight heparin. Bladder care by putting a Foley's catheter in the patient but with carefully, not to make the patient bleed. Bowel care, infections, early antibiotics, and eye care by giving carboxymethyl cellulose. Positioning of the patient, it is very important. Once the patient has recovered, tell him to sit, stand, and walk a little. In non-ambulatory patient should be made to walk a little or given a physiotherapy exercise to prevent contractures, respiratory complication. In unconscious patient, they should be kept in a recovery position. Change the patient's position every 2 hours during the day, and for unconscious patient and for the conscious patient every 4 hours during the night. Air matrices for non-ambulatory patients are very, very helpful. Swallowing, do a swallow test. It's known as GUS test, that is gugging swallow screen, or a water swallow test. We ask the patient to swallow 50 ml of water and see the gag reflex. Testing of the gag reflex is an invalid test of swallowing. So if the patient have an abnormal swallow, he should be put on a nasogastric tube. Patients who require the nasogastric tube for more than 3 weeks should go for a gastrostomy. In patients with altered sensorium, patient who could not take orally, patient should be put on IV fluids, usually the DNS or NS, for at least 2 to 3 days, followed by nasogastric feed. Oral care, frequent oral care should be there. There should be toothpaste, mouthwashes for the same, and patient should be assessed for dysphagia. Early mobilization is very helpful. Management of seizure and full loading dose should be given, and then the patient should be put on a maintenance route. Status epilepticus should be treated as per the guideline, that is giving of midazolam, uh, benzodiazepines followed by phenytoin or phosphenitoin. And it's not yet very clear that should the patient be discharged on anticonvulsants or not. For DVT, the patient should be first to prevent it. It's very important to prevent it before looking. So if it is due to ischemia, patient should be put on unfractionated heparin, BD, or low molecular weight heparin, OD. If it is due to intracranial hemorrhage, patient should be put on a DVT pump, routine physiotherapy, early mobilization. If on second to the fourth day you see that there is no hematoma or hematoma expansion, then the patient should be put on unfractionated heparin or low molecular weight heparin. You have to remember the mnemonic clots. Clots in legs or stocking after stroke trial does not support the routine use of tight length graduated compression stocking. So there is no rule of stocking in stroke. Treatment of DVT, you can give a unfractionated heparin, 5,000 units, or low molecular weight heparin. But before that, you should go for a CBC and a APTT to look at the values. And a rebolus of 20 units per kg should be started, and patient could be started on an infusion of 8 units per kg per hour. Given APTT is 1.5 times the control value. For using low molecular weight heparin, APTT is not required. Patient should be put on an anticoagulation, warfarin 5 mg once daily, or Cerebral 2 mg should be started simultaneously, and those should be adjusted to keep the INR at 2.5. Baseline INR must be done before starting anticoagulation with warfarin or Cerebral. Okay. Now, bladder care, indwelling catheters should be avoided. Intermittent catheters should be used. Bowel care, to prevent the constipation, the patient should be advised to take a good diet, IV fluids, exercise. If the patient is still not improving, then you can put the patient on laxative. And if still not improving, we can go for a rectal laxative. In case the patient is developing pneumonias, UTI, or DVT, then go for a antibiotic. Otherwise, there is no role of prophylactic antibiotics. Eye care, we can give polyethylene film, methyl cellulose drop, methyl cellulose ointments. Now, this flowchart is very important, that if the symptoms have resolved and they are rapidly resolving, then you have to take whole history again, physical examination, then assess for the BP, glucose, pulse, ECG, and RBS. Do an NCCT if there is a hemorrhage. Here, try to keep BP between 140 to 150 by 90. And if there is ischemia, or there is no hemorrhage, or it's a stroke mimic, then prescribe the patient antiplatelets, statin, BP lowering, folic acid, B12 to the patient, all along with the oral anticonvulsant. Advise the patient 2D echo, Doppler, lipid profile, Holter, vascular imaging. Now, the chart on the right side is very important. If the patient is coming to you uh, with stroke symptoms and he has come to you with less than 4.5 hours, first of all, get an NCCT done and confirm that it is ischemia, and refer the patient to the higher center where he or she could be thrombolized. If the patient comes after 24 hours coming to you with a severe headache, neck stiffness, altered consciousness, in these cases, there comes a very important sign of ABC, maintenance of vital sign, BP, RBS, lipids. For raised ICP, you can give IV mannitol at the same position. You can reposition the patient and elevate the head end by 30 degrees. You can give anticonvulsant, and then you can refer the patient. This way, you have almost ameliorated the symptoms, and patient will reach the higher center in much better state. So, secondary prophylaxis, what you can do when the patient has uh, undergone a stroke and he comes to you after 24 hours. In case of TIA, you can give aspirin 150 and clopidogrel loading dose followed by a maintenance dose for first 3 weeks, and then you can put the patient on aspirin or clopidogrel. But not beyond 3 weeks, because it will increase the risk of hemorrhage. In case of atrial fibrillation, you can start the patient on anticoagulation. In case of a non-valvular AF, you can start the patient on vitamin K antagonist and newer oral anticoagulants such as abixaban, rivaroxaban, and dabigatran. Patient should not be started on these drugs until or unless hemorrhage has been excluded out. For effective anticoagulation, our INR should be maintained at 2.5, except for the mechanical cardiac walls where we can expect our INR of 3.2. Blood pressure lowering, carotid intervention for the patient who are more than 70 years of age, a carotid endarterectomy can be done. While in the younger patient, carotid artery stenting is better. Intracranial atherosclerotic disease, blood sugar monitoring, MI, lipid lowering therapy, and lifestyle modification. And also, in case of hyperhomocystinemia, we give folate, vitamin B6, and vitamin B12. We assess the patient according to the Chartwa score, and if the score is more than 2, then we start the patient on oral anticoagulation. Even if the patient's score is 1, in case of male, you start the patient on oral anticoagulations. This is a much important question and much asked question, much discussed question. Most of the queries revolve around these, that what is a dose and what is a drug that should be started in a non-valvular AF. First of all, we have warfarin and acincamerol to keep a target of 2.5. Reduce the dose in elderly. It is contraindicated in chronic renal failure or hepatic failure. It has an increased effect with antiarrhythmics. Warfarin, the dose is kept 5 mg tablet and it is contraindicated in first trimester of pregnancy. Acincamerol, the dose is 1 mg, 2 mg, 3 mg, 4 mg. Initially, we have to start with 2 to 4 mg for 2 days, and alternatively, we can also give either you can give 2 to 4 mg for 2 days or 6 mg on first day loading dose followed by 4 mg on second day, and maintenance dose between 1 to 8 mg. And newer oral anticoagulants, dabigatran 150 mg BD, it has a higher risk of GI bleed. Rivaroxaban 15 mg OD, abiraterone is 5 mg BD, but if the patient's age is more than 80 years and weight is 1.5 mg per kg, in any of these conditions, they give 2.5 mg BD instead of 5 mg. Now, what we have to do in a physiotherapeutic management of the patient, in physiotherapeutic management, the patient must be attended by a physiotherapist in first 48 hours, then bi-weekly till the time of discharge, then weekly in the first month, monthly till the 6 months, and then biannually. Aggressive stretching should be avoided, and he should get a minimum exercise for 45 minutes for 5 days a week. So this is how first 48 hours he should attend. Then he should attend bi-weekly until the patient is admitted, then weekly for the first month, then monthly for the first 6 months, and then biannually. Now, coumarin and the diets. So there are some products. These are vitamin K antagonists which are useful for prevention of blood clots, and they are present in the daily diets. What are these diets? Like gobi, palak, chote gobi, hari fool gobi, dhania, muesli, lettuce, bhindi, sarso ka saag, tomato. They have a lot of vitamin K antagonists and they prevent the blood clots. Whereas our green leafy vegetables such as spinach, mustard leaves, coriander leaves, cauliflower, cabbage, tomato, egg yolk. These should be restricted, and mustard oil and soybean oil should be completely restricted in the patient. So these are the references from where all the info has been taken, and this slides has been made with respect to the guidelines which has been issued by the government of India in 2022. I hope it has helped you. If you have any doubt, you can ask me in the comment section. Thank you.